Yes, sir. Good evening, sir. My case scenario is a 9-month-old female with Pierre Robin sequence came for cleft palate repair. Initially, I'll ask the informant mother about the presenting complaints of the child regarding whether there is a history of any feeding difficulty or nasal regurgitation, and I would inquire about the recurrent infections in the child, any history of URI or any history of repeated ear infections, and I'll inquire about the appearance of the child. In birth history, I'll ask about the history of any drug intake or infection during pregnancy, whether it is a full term or a preterm delivery, and the mode of delivery is normal vaginal delivery or any LSES, and I'll inquire about the birth weight of the child and any associated congenital anomalies present in the child. In marital history, I'll ask about the consanguineous marriage or a non-consanguineous marriage. In family history, I'll inquire about any history of similar illness in previous child or in history of similar history in a mother or father. I'll inquire about the feeding history of the child, whether breast milk has been, how is the child feeding and weaning has been started or not, and any there is any history of nasal regurgitation, and how is the child fed now, and regarding vaccination history, I'll ask about the immunization, and regarding the developmental history, I'll ask about the milestones attained or not. General physical examination, head-to-toe examination, and I'll inquire about the child is playful or any history of infections or afebrile or not. Weight of the child is measured, and the head circumference. Any look for any pallor, cyanosis, edema, and look for the vital signs. Airway examination. Airway examination, since it is a child of Pierre Robin sequence, there will be retrognathia and glossoptopsis, and a cleft palate is present. And I'll examine the systems. In CVS system, if I hear any murmur, I'll ask for any echo, and cardiology opinion will be obtained. I'll ask for a respiratory infections are present. I'll look for a respiratory system in either active infections is present or not. And in CNS system, I'll look about the development of the child, any anomalies present or not, since it is an anomalous child. Investigations, I'll ask for complete blood count to look for anemia, and total count for look for infections, and coagulation profile, echo to be done if there is any murmur present in clinically, and chest x-ray to rule out any respiratory tract infections, and the x-ray of a mandible may be useful to assess the airway of the child. And if there is any recurrent otitis media, the ENT opinion can be obtained. The key anesthetic concerns of the child is this is a pediatric patient, and assessment of any congenital birth defects and the syndrome if present, and anticipated difficult airway, and separation anxiety, and it is a shared airway. It is a cleft palate surgery, and post-extubation laryngospasm is also a concern. Then preoperative assessment, I'll examine the signs of retrognathia and any difficult airway, anticipated difficult airway to be examined. If it is associated with left-sided cleft palate with bilateral cleft palate, laryngoscopy may be difficult. So I'll assess that preoperatively, and blood grouping and cross matching to be done preoperatively, as transfusion may blood loss is anticipated in case of cleft palate surgery. So I'll reserve blood for that. And anesthetic management includes, I'll set the OT temperature to 20 to 24 degrees Celsius, and monitoring ECG, NIBP, pulse oximetry, temperature, and precordial stethoscope is essential. Induction is done with inhalational sevoflurane, and IV access is obtained. During laryngoscopy, in order to make the scopy easier, gauze roll or dental roll is placed over the cleft to prevent any trauma. Then the patient is intubated with oral RAE tube, and the position of the tube is confirmed after positioning the child with mouth gag. We should look for the bilateral air entry and position of the tube. A throat pack is inserted to prevent aspiration. The ET tube position should be checked for any misplacement before starting the surgery. Maintenance of anesthesia is done with isoflurane, fentanyl, and nitrous and relaxant. Blood loss is assessed and should be transfused when necessary. And in order to prevent hypothermia, we should use fluid warmer or actively warming blanket should be kept on the child. At the end of the procedure, the throat pack should be removed, and we should examine the oral cavity for any swelling or any secretions or any bleeding before extubation. The child should be extubated fully awake and once full control of reflexes has been obtained. Post-op complications include laryngospasm, post-extubation croup, forgotten pharyngeal packs, in sublingual edema can be there. Most preferably the child to be extubated in the lateral or even in a prone position to facilitate ventilation after extubation.
Have you ever seen or anesthetized a child with periorubin?
No, sir.
Oh. You can understand that because you are saying about keeping a gauze roll in the cleft and all that. Have you ever seen a periorubin picture at least with the cleft lip and palate associated together? Where will you keep the gauze roll in which case? Cleft palate gap or cleft lip gap?
Cleft lip and palate.
Lip associated with the left side and palatal. But most of the time, or majority of the time, I can say, periorubin is only having a
cleft palate.
Complete cleft of the palate. It will never have a complete cleft running up to the alveolar margin. It will be a cleft only up to the soft palate, which is called incomplete cleft of the palate. So periorubin children usually have only incomplete cleft of the palate and never a complete cleft involving the alveolar and the lip margins also. Okay, that is point number one. Second problem is this is a clear-cut case of anticipated difficult airway. Why there is a difficult airway? Why do you find it difficult to intubate this child?
Because of the retrognathia, there will be glossoptosis and airway obstruction will be there. And larynx may be anterior, so difficult mask ventilation and a difficult intubation will be there.
Okay, what exactly happens when you try to do a direct intubation, direct laryngoscopic intubation, when you put the laryngoscope blade, why you are not able to visualize the epiglottis and glottis as you see in a normal case?
Because the mandible is retracted in.
So what exactly the word or terminology you should use to describe this difficulty? What do you do when you put a laryngoscope to visualize the larynx? Which structure you try to remove it from the visual axis? What is you are lifting to visualize? But before that, as soon as you put the scope, which structure you want to push away? Tongue. The tongue is the bulkiest structure that you have to push it to the left side and introduce your tube on the right angle of the mouth. That is how you are intubating in all the patients normally, isn't it?
Yes, sir.
So why you are not able to push the tongue away from the visual axis? Which area is not adequate enough to hold the tongue?
The mandible is not
submandibular area. Okay, that is the terminology that you should use when you try to do a laryngoscopy. You are not able to push the tongue and other soft tissues into the submandibular region, where normally we try to accommodate that during the normal regular intubation in a child or a person with a normal mandibular size. It is the submandibular area which accommodates the soft tissues when you try to push them away from your field of vision. On the contrary, because of the micronanthia, the submandibular space is inadequate. So you are not able to move the tongue away from your vision. That is the most important reason for inability to intubate these children. So what are the maneuvers by which you can try to achieve this pushing of tongue and visualize the glottis for intubation? That is the main thing that the examiners expect you to say. What is the maneuver that you can try to move the tongue away from your obstruction, tongue obstructing your vision, to visualize the glottis? Are you seeing my face in the camera?
Thrust.
Jaw thrust, huh?
Out using
okay. These are the two maneuvers which can help the person. So you can always have an assistant who can push the jaw with the whatever amount that he can thrust it forward. That will also bring the pharynx, open the pharynx. Other thing, somebody can pull the tongue with a non-injuring forces and pull the tongue out of the overall cavity, so that it need not be accommodated in the submandibular space. Okay, these two maneuvers will usually help. So this is one of the problem. These cases are kept in the exam as a short case, is for anticipated difficult airway. Securing the airway is very difficult in these cases because of the anatomical changes that are happening in that. How we are going to do that is the main discussion that will happen. And all other points that you said about, it's a pediatric case, it may have other congenital anomalies of the heart and other areas. All those things are all part of the thing, but the main discussion will be only about how to manage that. So when you know it is going to be a difficult airway, how can you achieve intubation in this? What are all the techniques? That is what the examiner wants to know. Whether you can go for regular conventional induction like giving propofol, relaxant, mask ventilation, and then putting your scope and trying to intubate with the oral ray tube. Is it so easy to go about like a regular case? Or what are the other adaptations you have to do in this case? Can you paralyze the child and intubate or not? That is the first very simple way of asking this question.
No, sir.
So when you cannot do mask ventilation properly because of the facial features, and when you are not sure of intubation, it is very, very dangerous to paralyze and make the child apneic. Then you will land up in a situation called cannot ventilate, can't intubate. EVCA situation will happen. So how to manage or how to overcome this problem? That is the answer that you have to say in the exam.
Inhalational induction with the spontaneous
respiration and trying to do a scopy and intubate. Very good. That is the first option. So if you are experienced enough, you can always take the child to the deep plane of anesthesia, but always allow the child to breathe spontaneously, and then lubricate the tube with the xylocaine jelly. And also, if you want, you can spray the vocal cords if you are able to see them after scopy under deep plane of anesthesia. And when the glottis opens during inspiration, you just push the tube in. But that requires a lot of experience and training. It is not a technique that a beginner can easily do. Then what are the next options? Any gadgets that can be used to intubate?
Awake fiber optic.
Awake in a small 9 months old awake, will the child be allowing you to do that?
So can we use video laryngoscopy?
Can we use?
Video laryngoscopy?
Video laryngoscope for 9 months old baby, I don't think it is available. But you can do fiber optic. Children fiber optic is still available. Pediatric fiber optic scope is available. So again, you can take the child deep by inhalation induction with oxygen in sevoflurane. Take to sufficient plane of anesthesia. Now, if you say that the inhalation induction and taking the child to the adequate depth of anesthesia, the automatic question that can be asked is, how do you judge or how do you know that the child is under the correct plane of anesthesia? Because in inadequate plane, if you try to intubate, what can happen?
Bronchospasm, laryngospasm.
Bronchospasm. Will it go for bronchospasm? Laryngospasm. The larynx is still active. It will be able to perceive the stimulus. So laryngospasm and breath holding is the most dangerous thing which can kill the baby because of apnea. Okay. So how do you judge whether the child has become deep enough to by inhalation induction? What are all the clinical signs of adequate depth of anesthesia? Supposing you start holding the mask and giving oxygen and sevoflurane to your baby, what will be the respiratory rate initially when the child is conscious and you are trying to put the mask and try to get the child under with the inhalation technique? Will the child be breathing slowly or will it be breathing rapidly?
Be rapid
It will be breathing rapidly, especially if the child has not been adequately pre-medicated and if it is conscious, a 9-month-old baby, as soon as it sees the mask and you are faced with you are wearing a mask and going to near the baby will definitely get frightened because it is 9 months old, it will have separation anxiety, and you try to keep the mask, the child will toss the head and not allow you to keep the mask, isn't it? At the time, the breathing will be very rapid. But once you keep the mask and then start giving, what are the types of induction you can do with sevoflurane?
Steel
Have you ever
induction.
tried any?
Steel induction.
What induction? You
First
start
we can
from
go
high
with 8
concentration
or
and come down to low, or you start from low and go to high?
To low. High
Then
concentration to low.
both are
patient
being
sequence,
attempted.
both are available.
Both
Patient
can be
operative,
both
we
can be
will go
done.
for 8 and
But
come
if you
down.
want to start from low to high, you have to also have not only oxygen and sevoflurane, but also nitrous oxide. Then it is easier to go from low to high value. Whereas if you are going to use oxygen and CO alone, then it is better to come from higher value.
too low.
What is the maximum percentage available in the sevoflurane vaporizer?
8.
8%. Okay, so you can start with 8%, and once the patient goes under, you can gradually reduce it to 7, 6 like that, and bring it to about 3 to 4 and maintain. So the rapid respiratory rate, what will it change to? Once the child becomes goes to the correct plane of anesthesia, how will the child respiratory rate will change?
Regular and
Shallow, slow and regular breathing.
slow.
Okay? Rapid, shallow breathing will become regular,
Regular and deep breathing.
deep breathing. Regular, when rate will become lesser. Okay, that is point number 1. What is the second point to assess the depth of anesthesia? What will happen to the laxity? Muscles will be tense or lax?
Relaxed.
Relaxed. So you can see the relaxation in the abdomen. Child will have a more or less a scaphoid abdomen. Initially, when they try to breathe hurriedly, it will be a bulging abdomen. It will become little scaphoid, or it will the muscles, abdominal muscles will relax. But what is the most important clinical sign to assess the depth? What will happen to the eyes, eyeballs?
Upwards.
It will roll upwards.
Upward roll is the inadequate stage of anesthesia.
Dilation.
Dilate. Which one will dilate? Pupil. The eyeball should become fixed in the central position. Okay. Initially, if you watch during inhalation induction of any patient, the eyeballs will be roving. It will be moving right to left, Okay.
Yes.
Once the child goes to the correct surgical plane of anesthesia, the depth of anesthesia is achieved. The moving eyeballs will come and get fixed in the central position. And once you open both the eyelids, the eye will be looking at the ceiling. This is called the central gaze. That is the most important clinical sign to assess the depth of anesthesia. So reduction in respiratory rate, relaxation of the abdominal muscles, fixation of the eyeball in the central position. These are the three important clinical signs by which you can say the child has gone to the correct depth of anesthesia. Then you can try your awake laryngoscopy, or your fiber optic intubation orally can be done through the fibroscope also. Okay, so that is the second method of achieving this airway. And the last, if both these techniques, awake spontaneous breathing child intubation or fiber optic intubation, if both are not successful, what is the next alternative to complete the surgery?
Phone, sir.
Huh?
Pent up.
I'm not able to clearly hear you. Tracheostomy. Okay, you have to do a tracheostomy. Some children who are born with a severe degree of periorubin may have complete obstruction of the airway even at birth. So they do what is called emergency tracheostomy in those children to allow them to breathe and survive. Okay, so the last option for us is to go for a tracheostomy to complete the surgery. So these are the three things that you have to keep in mind, and that is the reason why these cases are kept in the exam. So I'll just share the slide.